Yeah, this is rapidly
Great.
rapidly
So
evolving. I just got a note this morning that Google is releasing whatever the comparable equivalent is to what Apple Health released for
right.
clinical trials and data sharing, et cetera. So
Yeah.
it's, yeah, changes on a daily basis.
Yeah, absolutely. Absolutely. So just the other thing, and again, as we were looking at the project that we were doing, this whole topic of kind of the shared decision making, at the time, the AMA had just put out, kind of their document, their report on shared decision making as a best practice for informed consent. And essentially, informed consent is just making sure that the patient, the consumer is understanding what they're actually consenting to. And I think that goes back to what I was saying about ONC and, the presentation of all this to consumers. If you're a consumer, you're going through and saying, yes, I want to share this with my doctor. There's so many layers to your record that you may not want to share all of that. And so, making sure that there is this best practice of not only, presenting the information to the consumer and the patient, but making sure that they really understand it. And I know Michael's going to go into some more detail around that, in some of the best practices that we looked at around this. Um, and then just the last thing, just from a background standpoint, as Michael mentioned, again, at the time, kind of Apple Research they had just released this research kit. And of course, they have their personal health record. They just updated that even more now, that not only can you download your patient record, but you can also within the app share it with others. So this is just an ongoing discussion. What's interesting is when you look at the ONC and CMS rules around all of the sharing of data, this topic of consent, they knew they had to address it, but it hadn't been addressed in any of the rules yet. So a
Mhm.
lot of the kind of work that you're seeing done, a lot of the just focus on this now is industry, right, coming together to say, yes, we've opened up all this data, but now how do we make sure that we're sharing it in a way that is, that makes sense and that patients understand. Um, so I'm going to pause there. Any questions just on the kind of high level background before I turn it over to Michael? All right.
I guess one of the questions
Yeah.
I have, and maybe we'll get into this in a bit, is, this is all focused on healthcare,
Yes.
Mhm.
exclusively healthcare and clinical work. Do we have any sense that it extends more broadly than that, or it's adaptable to what any of the stuff we're talking about?
Well, I think when Daniel, when you see the framework here, yes, I think some of this could apply. Like we spent some time looking at your blog posts and your website, and some of what you're doing, and when you talk about social determinants of health, you're not really just talking about healthcare. Now you're talking about a lot of other dimensions, and as you go through this, I think we all in the back of our minds could say what from this framework could be lifted from a healthcare context and, for example, put into uh, a homelessness context, for example, or a social services context. I think there's applicability, but like everything else, there's some very specific aspects of the complexity of healthcare that would require this framework to be tweaked in those other areas.
Yeah, and I would just add to that. I mean, to me, there is a whole discussion, even within our industry, right, around capturing information around social determinants of health, who you're willing to share it with. There's the Gravity Project, which is another accelerator under HL7, is doing an amazing job of saying, okay, here are the data elements, here's how you should be capturing this information. But then on the flip side, there's all this discussion of, I don't want to share this information. I don't want people to know. So that's that layer, you have to bring in, right? Which is similar to what we're talking about, even just with our medical record on the behavioral health side, who directing who you want to actually share that with and how you make sure that the patient is understanding what information is being captured and what, who they're willing to share that information with. Because, when I sit in on these Gravity project meetings, there's a lot of just concerns about that we're doing all this great work, but then if people aren't going to trust that you're sharing the data in a way that they want it to be shared, a lot of this is going to be, unfortunately, fall by the wayside. So it is an interesting discussion even happening on, the health IT side in terms of SDOH.
I would, having said, I would recommend adding social determinants of health or social services to the healthcare rubric. We did that as part of the LEAP grant that we received from ONC in San Diego.
Yeah.
Because of our CIE and our 211 in San Diego. We'd already gone down that path. So I don't know how you don't add social services to the healthcare rubric.
Yeah, Dan, I think that's a really good point, and I would put that on a to-do list. Just keep in mind, and this may be a good segue into my segment. The main focus of this project, as Mary said initially, was advanced care planning. And as we got into advanced care planning, we found that e-consent, using Mary's term, was a service utility. So an essential component. But when we look at e-consent, it's really an enabler, part of a core application architecture that's going to support various applications like advanced care planning, like potentially social care planning. I'm not an expert in that area, but the point being is there'll be another application layer on top of this e-consent. That's how we view it. It's not necessarily how everybody views it, but that's how we view it. It's not a standalone application from our perspective.
Michael, I would just add that consent utility is not a Mary Stewards of Change actually convened a national action agenda and held a series of workshops that resulted in that need for electronic utility, a service utility around all of the various aspects of e-consent, and in particular, targeting on social determinants of health. So a timely topic, but yep. I can't take attribution. It was the effort of a tribe led by Daniel and the Stewards of Change.
So not to mince words, I know we have a lot to cover. I know, Michael, you want us to wait to the end, but Mary, didn't you just say that this is effectively a standalone utility, which in effect makes it a standalone app? Is that what you just said, Mary? Just to be clear?
Oh,
sort of disagree with what Michael just said?
So Dan, it depends on your definition of standalone app. In the Mary universe, a standalone app is a federation. So it's never just the one ring to rule them all. But having worked 30 plus years in health industry, there are very few standalone apps that are indeed that one critical component that is that sea change for health industry practices. In my humble experience, it's more of an evolution, and you get further faster with federation, with things like cloud computing.
Maybe another way to look at it, Dan, is it's, when you look at the framework I'm about to present on the success measures, if you could develop a core e-consent application that addresses these key success measures, then it could service different applications like advanced care planning, like clinical trials, the different types of healthcare e-consent that Pooja articulated. And then if we extend outside of those 4 types of e-consent, it could serve those different applications. And yeah, I agree, Dan, service utility seems to be a good terminology. Okay, so once we were done with getting our heads wrapped around what we mean by e-consent in the healthcare industry, that was the high level overview that Pooja just went through. We then went into the heart of what we needed to do for Mary and her organization And that is, what does an e-consent utility need to support? How should it be designed? What capabilities should it have? And the way in which we ended up structuring that is this framework of 6 success measures. And each one is somewhat broad, but has a certain definition and scope to it. So what I'm going to do is I'm going to just give you a review of, these are the 6 aspects of e-consent that are needed in order for it to be successful to support those 4 types of e-consent that Pooja went through. Adam, what we did here is we started with secondary research, and you're going to see at the bottom of these slides specific citations to academic and trade journal sources. So we started with that just to see what has been done out there. And you're going to see in here, there's some quite eye-opening research that has been done in terms of challenges and what needs to be done with e-consent. Once we did that secondary research, we leveraged the larger project, the advanced care planning, where we at Point of Care Partners, Mary's very familiar with this process, so is Dan. We have this voice of the market methodology that we use, where we go out to our network of stakeholders, people working in the field. In this case, people working at health systems that were trying to move the needle on e-consent as well as advanced care planning, people working in payer organizations, usually executive level people responsible for this. But we also did talk to some frontline clinicians as we were going through this. We talked to people in the emergency department, physicians in the emergency department about advanced care planning and e-consent. So the result here, what you see here, is based upon both secondary research and primary research that we actually did in the field last year with various stakeholders, clinicians, provider executives, payer executives primarily, and I think also, Pooja, some government officials
We did.
we talked to as well.
Yeah, we
Some
did.
government officials. Okay, so based upon all that work, this is the output. And the 6 success measures, the first one is a patient-centered model. And what this basically means is that the patient or the person, it actually develops a team that they are going to grant consent to. And within that team, who can see which classes of documents or types of documents. And I'm going to get into a little more detail on each of these after I give you the overview. But this is very much a patient-centric application or utility. The second key measure of success is that it must be a patient-to-many approach. A lot of the earlier consent, both paper and electronic in healthcare, it was between the patient and their doctor. So every time they had a different clinician, there was a new consent that needed to be informed consent process that they had to go through. Well, that isn't working very well in a large health system, for example, where a particular patient is seen in that health system by a primary care doctor in one town, and me personally, primary care doctor in Brevard, North Carolina, but the same health system, if I need a hospital or even outpatient surgery, I go 30 miles away to a different set of providers, but they're all part of the same health system. I want them to have the same consent, but to specific documents that I'm granting to my primary care doctor here in Brevard. And so a patient-to-many approach model is necessary for informed consent. Pooja talked about the shared decision-making, and there was some really eye-opening secondary research, and in speaking to some individuals, in that, we assume that when we go through with the patient, that, hey, and Dan, you'll relate to this, they give consent to share their EHR data over a health information exchange. Well, guess what? Research suggests if after they give you that informed consent, you ask the patient, what is a health information exchange? There's a very good likelihood they don't know what you're talking about. And so shared decision-making means that it's not just technology. There's some education, there is a human touch, there is interaction that has to take place between the patient and whomever is guiding that patient to the informed consent. And the shared decision-making could also include family members. If that patient has limited faculties, health literacy issues, computer literacy issues, when we talk about shared decision-making, we're talking about e-consent that includes not only the patient, but their family members. And then the fourth one, which I'm not going to belabor because we all go through this all the time with records, automated records, there has to be strong and trusted version control. We heard about an e-consent in the Epic system in this hospital in Southern California, and then that same patient gave a more current e-consent for the same purposes, but guess what? It's a year more current, but it's not in that hospital's EHR, it's in Dan's HIE. And as Dan points out, depending upon the provider you talk to, different providers will say, I want to be driving this e-consent for my patients. Well, that isn't necessarily, let me just say that that's subject to debate. If you want to have a patient-centered model, and as the pandemic and COVID-19 has shown us, a patient might have been seen by their primary care provider in Brevard, but because of long-haul COVID-19 is now being treated by the University of North Carolina in Raleigh. And that primary care provider isn't necessarily even in the loop with their care as a long-haul COVID-19. So we really need to look at that, but there are some cultural and ownership issues, if you will, here with this. And so shared decision-making, patient-to-many approach, patient-centered model, all need to get us, Dan, out of that patient-physician monolithic relationship. And then best practices for usability, which I also won't belabor because we're all this all applies to what you're doing in these other areas, platform agnostic, adhering to web contact accessibility guidelines, and so forth. So when we were done, actually, yeah, this was, I'm sorry, 5 success measures. When we were finished, we ended up with these 5 success measures in this framework that would drive any successful e-consent utility. Any questions or other comments at this point?
Identity was not listed as a success measure, Michael.
I'm sorry?
Identity management wasn't listed as a success measure.
We didn't really dig into identity management, actually, Dan. I mean, this was really focused on the e-consent for the advanced care planning. And so we didn't really dig a lot into identity management. I mean, that's a whole nother topic, right?
But it's a prerequisite for consent, which no one, which I don't think anybody would debate.
Yeah, agreed.
Yeah. So Dan, for this activity and what Point of Care Partners was asked to do, some of this was very much couched within the HIE. And so this advanced care relationship service actually embeds all of those components of identity of the master patient index. So we didn't really go into that as much as these success measures for what that e-consent service and functionality needed to incorporate. So some of that vitally important,
absolutely.
embedded Yeah,
Yeah,
those
but-
functions
but-
are.
but it is
embedded
foundational.
in
It's
the
absolutely
It
foundational.
is
Yeah,
foundational. And
absolutely.
actually, Dan, I'm so glad you brought that up, because one of the things I wanted to mention, and I kind of glossed over it, is if you look at in here, there's some references to ACRS on the right-hand side. For example, in the first one, potential model for ACRS and ACP. ACRS stands for acres, and it's active care relationships. It is a platform deeper than e-consent here.
Yep, yep.
That the Michigan Health Information Network has developed. And that's where the identity management would take place.
Fair enough.
Okay?
Yeah,
You're
makes
familiar with
sense.
acres?
I am familiar with it.
Yeah, so you know what I'm saying then.
I do.
That's where the identity management would take place as an attribute of the person in acres. Let's go to the next slide. Any other questions? So for the patient-centered e-consent model, we just put together a conceptual model of what it might look like, what the patient portal, what the architecture of the portal might include. The essence of this is twofold. One, we see it as a portal that, for example, would be connected or embedded within Epic's My Health Record, for example. So it would be a portal model. And within that portal, the patient creates a personal healthcare team, selecting providers on the team. And then it's almost like a matrix in that here's the members of the team. And for each member of the team, here's what classes or types of documents that member of the team can have access to. And the member of the team might not be a person. It might be, for example, critical care at the health system, because you don't know what hospitalist is going to be on duty in the event that an individual might need critical care at some point in their healthcare. And so it's a personal health care team, providers on the team, document classes or types, could restrict on time periods. This particular consent expires at the end of 2021. And there's an audit trail on who has viewed what documents that the patient could see. That encourages the patient centricity. And as Pooja mentioned earlier, the key here is that this architecture would be built to be interoperable with IHE-based architectures. As part of this, simplicity is key. One of the things we learned is that the training of patients and usability were identified as complex challenges. And this is where the Making Choices of Michigan services that Mary is working with, that model where it's not just technology, there's a human touch, and education and training around it is so critical.
Yeah, so I would just add to that, the Making Choices Michigan, an organization that both does patient advocacy, works with the stakeholders, including technology stakeholders in this space, works on advocacy for changing policy and state legislation, but just a fleet of staff who interact with individual patients, with their social work, to make sure that their information is available to their care provider or those who are engaged in that patient's care process. If it's guardians, if it's foster children, if it's all of the complexities that Project Unify and the INC program certainly brings to the table. I think the important point there that Michael made is you still need a human touch. You can't take folks who are maybe distrustful of this electronic system and say, here, we need all this information from you, and expect it to be entered into the system.
Next slide, Pooja. And so the second success measure was the patient-to-many approach to informed consent. And this reinforces what you raised earlier, Dan, in terms of the traditional physician-patient relationship. Instead of a traditional patient-to-physician relationship, this model should be between the patient and the organization, with other healthcare professionals that are involved in the patient's care included. The hospitalists, maybe we expand this to other stakeholders in social determinants of health that are interacting with the healthcare workers and are connected to the EHR as we continue to advance interoperability and embed social determinants of health into the EHR. And Dan, to your point earlier, look at the second quote here. We got this from an emergency room physician. The direct quote, "These documents need to be owned by the patient, not the physician. Healthcare is moving from physician-centric to patient-centric, and this industry movement should help move this forward."
Is this an appropriate time for a clarifying question?
Please.
When you move the model to consent for the organization or the system, is there a loophole if there are doctors I don't want, or is it mandatory that it's everybody in the system? What if I don't want everybody in the system to have my information?
Yeah, that's a good question. We really didn't get to that issue. Our assumption was that the organization would drive what the taxonomy, if you will, of the organization would look like. So critical care, emergency care, acute care, behavioral health, and then each of those entities could be chosen by the patient as an entity within the health system that could be granted consent. So there is some definition that needs to take place on the provider side, at the organization level, at the departmental level.
But just to clarify, if I may, Adam, aren't we advocating break consent by organization? Because if organizations still control consent, right? This becomes incredibly difficult.
But isn't that, yeah.
Consent needs to be ubiquitous. It transcends organizations, regardless of what ED I'm in, regardless of what urgent care I'm in. Consent needs to be ubiquitous across organizational lines. And if organizations continue to own consent, I think we're compromised.
Well, Dan, I don't think that's what we're saying here. We're saying that the patient determines which organizations and which providers within those organizations are granted consent to their records.
Well, it's difficult within functions within organizations versus organizations organization-wide. And I think we should be crystal clear here to the very best of our abilities.
Okay.
My question, I think there's a double-edged sword here. If a patient, and maybe this is such a small minority of people that you can't make the rules for them, but there's some number of people, however small, who, when they're asked, will you give your consent to whoever is in our system, in our organization, it might think, well, I'm okay with most of these, but I have this other doctor, I don't want him to get it. And the risk, is there a way to register that? Because it might be fine. 99 doctors get it and one doesn't, but that's a hell of a lot better than nobody getting it. And two, there's, I guess, a risk for some minority wherein that person says, no, that means Dr. X can get it. I'm not giving it to anybody.
Exactly. And our assumption here, having not done the detailed design, was that that could be a choice at the acres level. So at the acres level, the person can choose the type of the information and who can see that information.
Mhm. Okay.
Just
So-
real quick aside. I did this at a board meeting. Same patient, high utilizer. So had lots of records everywhere. We brought up eHealth Exchange next to Epic, next to Cerner, next to the HIE. 2 out of the 4 consents contradicted.
Mm.
We will know we are successful. We can bring up a record in any setting and consent is consistent.
And Dan, the point of care partners work here because it was through the Interoperability Institute and looking at enhancing that active care relationship service. So some of this is intertwined, but with the notion, we've now taken the findings of the point of care partners data and building out that functionality so that we have functionality to say, you know, the different layers in the tier. Does this patient have an advanced care directive? Where did it enter into the system? Was it through a patient portal? Was it through an EHR? Who are the actors in this patient's care provision? And do they have rights, or does the patient need to release rights like to their health plan to be able to have that information? Is there CFR 42, et cetera? So the whole matrix of functionality, taking the findings of this work and lifting that into building a service that basically serves as that registry for those relationships between this person and all of the actors in their healthcare processes.
Thank you, Mary. So any questions before we move on to shared decision-making? Let's go to that next slide. So as I mentioned earlier, from our research, conclusion was, and I think you just alluded to this, Dan, the e-consent for health information exchange without human coaching is fraught with it being implied consent, not informed consent. And so the other thing is, like, what we learned is that since you need that human touch, which isn't cheap, the best approach here is to treat e-consent as a utility. And so, for example, in the context of advanced care planning, when you are coaching the patient and their family on advanced care planning and how to create the electronic document and sign that electronic document, at the same time, you educate them and coach them through the e-consent process. So if we're talking here about the other type of e-consent, where you're sharing the information across the HIE, perhaps that portal that the patient's using with the HIE, like I use with the University of North Carolina system, when I'm being shown how to use that portal and how to use the telehealth aspect of that portal and so forth, it's at that point that I am also educated, trained, and coached on how to complete the e-consents for any providers within the UNC health system that I want to provide consent to access my records. So again, we're not it's more cost effective and more better relationship with the patient, consideration of the patient, if you will, if you treat this as a utility that is part of the training, the education, the coaching of the application that it might be supporting. Questions? The next one, strong and trusted version control. Really, just as I mentioned earlier, we heard a lot of issues with different versions of advanced care plans, electronic ACPs, and different versions of e-consent located in different places with different dates. The implication of that is the need for a strong, and I think, Dan, you were alluding to this earlier with your notion of the registry. We need a strong model for either a centralized model of a directory of here's where all the e-consents are, here's the version of the e-consent, here's when it was last updated, and if there is an expiration date, here's when it expired. Now that particular registry or directory doesn't necessarily have the ACP or the e-consent stored within it. It kind of works like we're now familiar with master patient indexes and patient registries, where it might just be an index, but we need this centralized model. And yes, we need to explore, it was beyond the scope of this project, but we need to explore blockchain as a possible technology to support the audit trail of changes to e-consents and an audit trail of the various versions. This is key to trust. If a provider has access to an e-consent and they are at the point of care and seconds matter and they see an expired e-consent, they're not going to use that system anymore. So trust is really critical. Version control here is really critical to trust. And our takeaway box here, when we were talking to the Michigan Health Information Network team, the positioning of e-consent along with advanced care planning in the ACRES platform, it's important to convince the health systems that this centralized directory registry is a better model than the e-consent being stored at the EHR system at Sutter Health. Questions, comments?
I would only add that's a tough sell to the academic medical centers
Yes.
who have a big swag of population, but most of them have Epic. Oh, the Epic portal does that. We're all set. Yeah.
So along to follow up on that, does Epic understand that everything isn't all set and that there's some risk to them if they don't expand their view of what they have to provide? In other words, is this a remediable problem by Epic?
Yeah, so Epic's doing a lot of work. I mean, all of the EHRs are because of the interoperability rules and having to actually, allow, so when the patient gives their consent, to share their medical record. So they are starting to look at this different aspects of it. That's being obviously built into the patient portal, but they are, but the problem with the Epic system, right, is each instance is you have to upgrade, you have to change everything. So even if they put it into one of their releases, having that information isn't necessarily going to be across all systems and all practices. So, but it's something that they're starting to tackle.
Yeah.
And using Epic as an example, we have to be careful because Epic's philosophy has always been, and many of us on this call are very familiar with this, their philosophy is, look, the customer makes the decisions. Yeah. They decide how to configure it. They decide what applications they're going to use, which, to Pooja's point, is what makes it so difficult to upgrade new versions of Epic. When we talk about the e-consent collaborative, it's absolutely essential that the large health IT vendors be at the table because they have to understand this. They have to understand that a monolithic model is nearsighted and will lead to problems, particularly as we've learned from the pandemic, and it's a priority with ONC. We want interoperability with the public health agencies. We want interoperability with the social services agencies. How is that going to work if all the e-consents are in Epic's garden at Sutter Health? It's not going to work.
Yeah, so interestingly, just a current fast forward snapshot of the marketplace. I don't know if folks have seen that Cerner and Vinca, particularly under Project Genesis, which is the military health service and VA coming together, have worked a business relationship. So Vinca getting into that repository space, independent of core function of the EHR. What I've seen of Epic to date is this is a market opportunity for a new module for their patient-centered, what is it, patient-centered home initiative for the patients to have that through the Epic web portal, which leaves us with the AD Vault, which as best I can tell in my engagement with them through some of the HL7 accelerators, but also through some of the VA activities. AD Vault seems to be kind of getting this repository piece right.
Yeah.
They know what their bumpers are, they know where their market opportunity is, and they know they have to collaborate. At least the words are right when you talk to AD Vault.
And then lastly, Pooja, the best practices for usability.
Yep.
The people on the call here from the both institutes probably know more about this than we do. And so I'm not going to spend any time on this unless anybody has any questions, but it's the age old, making sure that this is a user-centered design. We really focus on usability. We're sensitive to health literacy issues, computer literacy issues, disability issues, vulnerable populations with limited access to broadband, and so forth. We need to take all that into account as we build this application. And so I'm going to close just by saying that the intent here was a framework for Mary and her organization to use to develop in more detail, a more detailed design specification for e-consent, using these as the best practices, the success measures, the goals, if you will, that when we're done building e-consent, we want to make sure that we can nod our heads and say, it has accomplished each of these 5 success measures.
So Pooja or Michael, can you share how many interviews? I know it was like more than a dozen, but I think it was less than 50, just a ballpark number of the lift for the data that we collected on the healthcare side, because the stewards of change needing to do that on the social services side. But it's a pretty significant lift.
Yeah, Michael, I don't remember the exact number. I think we scheduled like at least 15 maybe.
Okay.
If I
And for how
remember.
long was it did each interview last, ballpark or average?
So
30
we,
to 60 minutes.
yeah, yeah.
And
we
they
have a
were,
pretty,
they were like this. They were in person. They weren't surveys. They were interactive discussions. And Dan's familiar with our process. We send a discussion guide out in advance. They get a chance to think about it, and then we sit down and we have a 30-minute, because of the pandemic, 30-minute video calls
Mhm.
with them, with some email follow-ups. If we had additional questions, they were all very happy to reply, continue the communication via follow-up. And maybe what we, if I may suggest, we
Yeah.
could go, it's been a while, like Pooja said, it's been almost a year. We can go back and see what the number was, and for that number, what types of organizations we
Mhm.
spoke with. Mary, if you're comfortable with that.
Yeah, well, and then subsequent to that, Ed and I coordinated an industry day just on, okay, if we build this, will they come? Where's the interest? Bringing together all these different stakeholder viewpoints. We had over 300 individuals interested in that, and it was a lot of organizations. We'd have to look at the discrete number of organizations. But that was a really good discussion that set some of the basis for where the stakeholder interests clearly an interest from both public sector, ONC, CMS, VA, and private sector companies, academia, et cetera, across all the different roles, that important to bring these viewpoints together. And one of the outcomes of that industry day was the business process modeling, the BPM Plus, took the patient journey that Michael had produced as an outcome of this and actually put a working demonstration together of the e-consent focused on advanced care plans, what that patient journey would look like in computable syntax.
Yeah, and you also clearly did a lit review or some variation of the
Yes.
theme, because you talked about the surprises that you came up with. How did you, it's a big world. Right? How did you limit, how did you put boundaries around what you decided to examine and what you did not, and what you ultimately used and what you did not?
Well, Adam, actually, we took a scholarly approach to that, in that, we wanted to stay limited to electronic consents
Yep.
within the healthcare setting. We created a series of keywords around that. We have access to a pretty extensive online university library.
Uh-huh.
You'll see a lot of those references are from peer-reviewed journals. And so that's what we did. And if from that point, it was subjective in that if we just didn't think the article really contributed to what we were trying to do, we didn't include it.
Sure.
There was some stuff in there in the weeds of the technical architecture, which was really not in the scope of this project. So we didn't use that. There was some in there, other countries. For the most part, we didn't use that. So that part of it, the delimiters for what we used were somewhat subjective, but we did a pretty extensive literature search using this university library. I'm pretty confident, as of the date of this work last spring, that it pretty much covered the bases. And
Yeah.
what made it easier, Adam? There isn't a lot out there on e-consent in healthcare.
No, of course.
Yeah.
And we will find even less, so
Yeah.
easier yet.
Yeah.
But so one last one for now.
Sure.
Did you, when you sent out your interview guide, did you strive to have a level of consistency across all of the interviews, or were they more tailored to the individual and the individual project?
That's a great question. The discussion guide was tailored to the type of organization. You're not going to ask the same questions to a physician in the ER as you are to a payer executive.
Right.
So the discussion guide was tailored to the type of participant, but we consistently use the same discussion guide within that type.
Those types.
Yes.
So
With that said, we were very clear both in our introduction to the discussion guide and at the top of our call. This is a guide. This is not a structured interview. If there's particular topics in this guide that you wish to drill down into, more so than others, we will facilitate that. And the reason for that, and it became really clear, especially when we talked to clinicians, they had some pretty passionate thoughts they wanted to share with us on certain topics as opposed to others. So this was not a structured interview and it was not a structured survey, but the discussion guides had a consistent set of topics for that particular type of interview.
I get it.
And,
I
and just
really
to
get
add
it.
to that, I think, we tend to, at Point of Care Partners, one thing we do when we do these interviews is, it's hard to get these people, these executives, right, for 30 minutes for a discussion. So a lot of times we'll offer, and we do this, I think, with most projects, a summary of what we've learned to give back to them, right? Because if it's a topic
Oh,
they're
that's right.
interested in,
That's right.
right, it's important for them to get something out of it as well. And so as opposed to doing like a monetary thing, our learnings, of course, we don't give them everything that we give to the client, but a summary of our learnings from others that may be in the industry is really, I found that, the participants are really grateful to get that, because they're solving a lot of the same challenges, right, that we're asking about. So
a funny thought came to my mind. So I was a journalist for 20 some odd years. So I've done thousands of interviews in my career. And the summary that I gave back, that we gave back to the interviewees, was in the newspaper the next morning. But I think, but I take your point. I think that's really, it's smart and valuable. It gives back something to them for the investment of their time. Is the interview guide something we would not crib it, we would not plagiarize it, but is that something you would be willing to share, so I can just get a sense of, again, trying to align apples with apples as we conduct our work?
This is Ed. If I can just interrupt, since
Yeah, sure.
This work was done for the Interoperability Institute.
Sure,
All
they
those
own it.
the questions are Mary questions.
Yeah.
Yeah, so let me jump in there on a couple things. First, your original question, Adam. The Point of Care Partners team did a fantastic job collating, and then we reviewed those potential candidates.
Mm-hmm.
And very much the healthcare side was couched within the Health Information Exchange. So interoperability around e-consent. And we made selections for, we don't need, nor do we have the resource capacity to interview 50 academics.
Sure.
Let's pick a representative. The EHR space, we know who the market leaders are there. Let's focus on them. I think we made some strategic decisions around a couple of the big health plans, 2 or 3, whatever that was, to really focus the data collection, because that does take a lot of lift, and you can't, much as we would love the luxury of that time and resource, we made some strategic decisions there.
Sure.
And Adam, on the second question, what I was hoping coming out of today is just what that package might look like based on this conversation. We can provide a short list. Having met Michael, Pooja, Ed, I would strongly recommend seeing if for this effort, a little bit of their time to help with some of the lift of collating this into the resulting publication. But I would want to see those different artifacts because I need to run them back through our legal office and get the formal release of what that's going to look
Sure,
like.
of course.
Yeah.
Of course.
And one thing, I think we all know this, but I feel obligated to state it. When we decide to interview a participant, it's very clear that they will remain anonymous. So we can give you the type of organization.
Right.
And the type of
Right.
individual, but no names.
Yeah.
Fair enough. Great. Well, you did a heck of a job, guys. It's impressive work.
Thank you.
It was a good piece of work, and I have to say it really did push us forward on both the national dialogue, but then also the internal organizational reflection from both the MiHIN enhancing that advanced care relationship service, but also the Interoperability Institute, looking at innovations like blockchain, like all of the identity management that Dan mentioned earlier on, and how the technology infrastructure with this electronic consent service fit together so that we're truly providing a value add to the industry.
So one thing that occurs to me is, I think this is true, some of the value, Mary, hopefully that you will get out of this is putting your work out into the world, which I think is great, and the world should have it. But also we will put out our work to you. I mean, there could and should be some real value in what we learn to you. It will inform you. It could affect, how you proceed in some things. So hopefully everybody gets something out of this.
Question. Any thoughts based on the research to separating mental health and substance abuse disorder from treatment?
Well, as Pooja mentioned in the high level, we did see that as we want to conform to that statute on substance abuse disorder. And we see that as a type of document. So the e-consent most likely would have, here's e-consent for your medical care. Oh, by the way, here's a completely different e-consent.
Yeah, and we didn't really dive into that, Dan, for this project, just because we were doing in the context of ACP. But yeah, that's, it's to me, it's one other document, but of course, a mandated, right, one, as opposed to kind of the work that we were looking at, which is, is not mandated yet.
And Dan, Interoperability Institute has been tracking some of the advanced directive work that the HL7 community is working on, juxtaposition with the Gravity efforts in the SDOH. So Gravity focused, I think most recently, Brian might be able to help me with this, for those diagnosis codes, the ICD-10s and SNOMED, to be able to actually get the different clinical classifications embedded into the SDOH, in addition to modifying SNOMED, for example, to include ethnicity and other data elements. So been tracking that activity, but I think it's still an evolving area.
It's certainly something that has either been dealt with already or is on the drawing board for coming work starting in the fall. We're about to take a break over the summer.
Yeah, I'm very keen to see what happens with some of the blockchain, the electronic wallets, and those consumer-driven models. A study in the making as to availability of the technology in consumers, those 20 to 30-year-olds who don't care about their advanced care plan, and then the 50 to 60-year-olds trying to figure out the advanced care plan for their 80-year-old parents to get it in the web portal correctly, et cetera, et cetera. So Interoperability Institute, using our student workforce program, looking at ways that maybe we can use those students to help to mobilize some of the social change and need there.
Great. So I think just the last thing, Ed, I don't know if you and Mary wanted to share anything about, I know you mentioned the industry day. I didn't know if there was anything else. I think that was the last thing we had on our agenda.
Well,
So for the group here, I have shared on the National E-Consent Collaborative. Ed, I don't know if you collated any materials or if we want to just bring up the website. So if you look at
I might have to
E-Consent Collaborative, where we're posting outcomes of those activities, lots of interest in bringing together a collaborative to work jointly around moving the bubble forward and e-consent.
But Mary, is that, or for other folks, this is Daniel, is that again strictly focused on sort of healthcare, clinical kinds of care in terms of the e-consent collaborative?
It is not, Daniel, it really is all of the aspects of electronic consent, driven by those who are willing to put the resources on the table and the problems that they're interested in solving. So a couple of the big health plans, very interested in driving this forward, particularly around SDOH. Some of the care providers, sorry about that noise. Getting a little weather blowing through here, but not a tornado. So that's good.
That's good.
And so really just driving that as a community-driven effort.
But more specifically, are there, I understand the reason for, healthcare insurers and plans to be at the table. That's you know, obviously the value and the importance is pretty clear. Has there representation from education, from justice, from behavioral health, from social services?
So Daniel, I was leaning into Project Unify and some of the maturity of Project Unify to actually bring that component to the table for the collaborative. But I'm a collector. I'm very much a person to do the collaboration. I know Project Unify is very focused on the needs of the Inc. community at the present time, but a lot of the work there should be able to be reused for education, for justice,
Absolutely.
for some of those other components.
Yeah, absolutely. That's the idea.
Yeah.
And I have to say, for some of the National E-Consent Collaborative, it's focused on some of the technology and the infrastructure that is needed, the registries that we talked about earlier, standardizing on the APIs through HL7. It's just a lot of lift to be done in this space.
If I may just add, I'm not involved with the this collaborative, but the one thing that I know is really critical to any collaborative, and Mary alluded to this earlier about the first day they got people together with the journey, is when you bring in other stakeholders, the value that the collaborative has already brought to the table is this framework, for example, and also, you know, how do we get traction like right away with the stakeholders? How do we engage them? What's in it for them? And I think the journey, the e-consent and the ACP journeys that we put together gets people to lean forward from their chairs and they want to learn more about it.
Yeah. I just have a broad question as we sort of frame this, which is, as we look at sort of the other, you know, other parts of the universe here, as I said, you know, whether it's education or justice or other social care programs for which consent is required or desired, lining these things up, right? So if we think about we would probably refer to it as the person as opposed to the patient, right? So who that person, they have some healthcare needs maybe, you know, they may have other needs as well, the different influence. As we think about how to advance this very radical idea of actually having a utility, right, that is ubiquitous, I wonder, this is a kind of teleological question, but I wonder if it's even doable, right? You know, can you show somebody a screen that says, okay, yeah, I want to consent to sharing my educational information with the school nurse or for other reasons, and my education, my attendance data, and you know what, I want to share this, you know, I want to get my kids back, so I want to share everything I can share because that's going to help me, versus somebody who's, you know, only interested in sort of the healthcare side. I'm trying to articulate, are we, you know, sort of Macintoshes and Gala apples, or are we sort of pineapples and sort of like plungers here in terms of trying to look at these things and saying, is there an electronic consent that's ubiquitous enough to go across so that somebody could actually choose which parts of it that they want to use, and it would look relatively the same?
I think there's a couple pieces of that question. Is it doable from a mechanical infrastructure perspective, or is it doable from a consumer perspective? I don't see Apple, Google, Microsoft, those guys shying away from the idea of having something ubiquitous for the consumer to use. And from a consumer perspective, I think learning how to manage a consent portal in a larger sense is an advantage. But from a technical perspective, you know, every day people are coming up with new solutions to consent in their own little niche. Maybe it's this hospital system or, you know, this housing authority, whatever. So, you know, I think that's an excellent question, Daniel. It's a big task, and there's a big answer to that. Is certainly a worthy objective, in my opinion.
Yeah.
And I would hope Daniel, that if this framework resonates with your team, that perhaps you test it. You know, that's the whole purpose of the collaborative,
Right.
is test it and see if it holds up. The devil's going to be in the details. I mean, you're going to have to deal with FERPA for education, HIPAA for healthcare. You know, there's going to be a lot of quote variations, but is there a common framework that can support this e-consent? I'm an optimist, so my initial hypothesis would be yes.
Yeah, I was
So-
going to add that too. I think that I think the technology is there. It's the regulatory pieces. I mean, all the layers in healthcare. But I would say that if we can figure it out in healthcare, that probably is transferable to other things, right? Because there's so many different layers that we're now dealing with, that you could develop a framework kind of based off of what we're doing in healthcare and bring that out to other industries. So.
Yeah, that's a great
Daniel-
point. I'm sorry.
I would add for the sandbox environment that Interoperability Institute's providing in the synthetic personas, we're describing those, at least the initial proof of concept, as a proving ground. So I would endeavor to say that the current status of the Project Unify demonstration is a proving ground. From that proving ground, is there a community of interest? Clearly, there's an Inc. community of interest with use cases associated with that. But there are probably additional use cases around a community of interest in the area of e-consent. And some of those activities in the public domain as a proving ground, but some of them potentially for business purposes with the EHRs, with an AD Vault, with a Vinca, where they might want to do some private exploration, leveraging that framework. And I'm still very keen that components of the direct trust framework will be really key here for some of the identity pieces that Dan brought up early on, but also all of those aspects of that consumer focused access and the technology mechanisms underlying those. What does that wallet, that blockchain, that key look like?
I think I think we're good. I think our team has to regroup a little bit and figure out, you know, what do we got and what do we need, so to speak, and get back to you. I think certainly some of what we discussed today, and I sent you all an email earlier, would be useful. But Mary, as you said, you need to get back to your folks and see what's doable, what's not doable, and that's fine. I'll just repeat that to the extent that you can be, you know, vaguely transparent, it would help guide us into aligning the work, not nothing more than that, I don't think. And for the purpose of the final report, it makes sense as well, because it wouldn't sound like we're reporting on two different things. We would be reporting how all these pieces fit together.
So as a way forward, Pooja, Michael, Ed would ask if you could just provide me with a bulleted list of the different artifacts, kind of how they're packaged up. I know I've got the package somewhere, but I'd have to go diving for them.
Great.
And then Adam would propose that we'll put together something akin to a data sharing agreement, whatever the legal folks may want to call that, is to, here's the intellectual property that Interoperability Institute developed. I would say, knowing the complexity of that information and the data and the analysis, as part of that agreement, I would strongly advocate for a subject matter expert from Point of Care Partners or portions of Pooja, Michael, Ed's time to help with the list, just so it's not misconstrued of, oh, great, we have this study vehicle. I think it's just important because the nature of the work was very much couched within the HIE context. And then we can look at moving forward.
Yeah, makes lots of sense. The one thing that is worth asking is how long will this take? Just because we have deadlines and we want to get going. And if, you know, to whatever extent you can expedite all of that, that we would be grateful.
So the only thing I would say, Adam, is I'm desperately trying to take some personal PTO this week before the 4th of July holiday break, but I think we can probably get
Fair
something
enough.
pulled together. And I don't think this would be very complex, just for the agreement between Stewards of Change and Interoperability Institute. I mean, we're a member of the NIC, we're a member of Project Unify. I think it's just making sure that we have our ducks in the row, and there's the infamous principle of least astonishment. Let's just make sure there's not any astonishment.
Yeah, I would add the principle of trust but verify. No, now the lawyers come in.
Yeah, well, just to make sure that we know exactly what
Absolutely,
that
that's the
is,
verify
what's
part.
being shared, and
Yeah,
what the
100.
intended use is for it.
Yep.
Yeah.
Cool. Great. Thank you enormously to all of you for setting this up, for giving us a terrific presentation. I mean, that was very, very good. Appreciate
Thank
it.
you. Thanks.
Absolutely. It was nice meeting you guys. Yeah.
Dan, are you still in San Diego?
I am.
Good. I'll have to come see you when I come for the winter.
Yeah, please, please. In fact,
Absolutely.
I was over Mark Branning's house Sunday for his 70th birthday.
Wonderful. Wow. That makes me feel
Dan,
old.
I miss San Diego. I was a IPA contractor based out of Point Loma. So I've been back and forth to San Diego way too many times over the last decade or more. And yeah, it's beautiful there. You're not burning up because you're close enough to the ocean.
Not at
Do
all.
people actually leave San Diego? Is that a thing that happens?
I don't think
Well,
so.
Not that I know
Although
of.
I'm
I
in
had one
Phoenix and we
colleague-
have a whole contingency that goes over there all of July. Like pretty much all of Phoenix moves to San Diego in July. Those are the only people coming back, I think.
I had one colleague move from San Diego to Malawi, but
Ah.
that was for good reason. She wanted to
Okay.
do some field experience.
All right.
That's acceptable.
Thank you,
Okay.
everybody.
Great to meet all
Yeah,
of you.
thank you,
Thanks.
everyone,
Okay.
very, very much.
Thanks, everybody.
Amanda, I will send you a new invite, okay?
Okay,
Thanks.
Be
Okay.
well all.
Bye-bye.
Bye,
Yeah.
everybody. Thank you.
bye-bye.